Okay, we're going to kick off our next session, which is entitled Ultimate Structural Cases. And with that introduction, we'll kick off.
Queen, come join us. We need an imager.
Nadira/Queen, please join us. We will have the first case presentation by Kashish Goel, which is entitled
Only if you're capable. Only if you're available.
Pseudoaneurysm Closure. Thank you for being here, Dr. Goel.
Nadira, settle in. Thank you. So again, a great conference and great cases. So we'll start with this pseudoaneurysm case here. These are my disclosures. This is a 49-year-old male referred for aortic pseudoaneurysm closure. So he had a hemi-arch replacement with a 30-millimeter graft and a mechanical Bental with a 25-millimeter St. Jude conduit for type A Stanford type A dissection about 6 months ago. And had this follow-up CT at 6 months. That's when the surgeon called me. This is the best image I could get. So you can see the aorta and then the mechanical valve and then something next to it and then a big sac almost equal to the size of the aorta. Patient is actually asymptomatic overall. And then these are some of the T images that we saw. And I think the question now is percutaneous closure an option? And if yes, what route will you take?
Okay, the panel. Let's see what you have to say.
Can I see that CT one more time?
Yes.
So where do you think the entry point is?
So it's basically just posterior to, again, but this is it is a very small neck. So that's why I scanned the CT even for this everywhere, whichever way possible, but we just see something next to the valve, and then you see a big sac. So the question is it a paravalvular leak that's leaking around and going to the sac, or is it a suture issue that happened? But yeah, I can't get more than that.
You don't see the actual entry point to the pseudoaneurysm.
Not on CT
yeah.
very
And
well.
you can see the suture line a little bit above the ST junction where the Bental ends. So it's not at the distal suture line.
Yeah, so like
maybe at the proximal.
Oh, sorry, yeah. So basically, this is the mechanical valve, aorta, and then big sac, the delayed phase contrast CT. And basically, I had my best radiologist, Dr. Carr, who helps us a lot actually he did this prior to this as well. And we basically saw this, you can see the contrast is the same, and then it's delayed phase here. So we know something goes from somewhere here, then fills up. And obviously it's a concern because the sac is pretty big. And he's 49.
And how long ago was the surgery?
6 months ago. The type A, and it's a Bental. So the question is, I think, if you remember last year, I think Abdullah presented a case, and then Jason was like, why didn't he go transeptal? So one of the things here is, where would you go, in terms of approach if you do want to? So I think those are the questions I had thinking about it.
I honestly think it depends on just where you think the entrance is, and I'm lost. I don't exactly know where the entrance is.
It was like your case on T that we were lost
Yeah.
to. You can see this is an off-axis. So this is the sac actually. So it fills up here, and then it fills into this sac. Because when you do your regular long axis view, you just see a little bit of color.
I mean, if it's a Bental, it's basically got to be either at the level of the valve or at the distal anastomosis. So it's got to be somewhere down there, but exactly where nobody knows. And
I thought it was right at the because on the CT we saw it's like right close to the valve. So it has to be somewhere it was sutured close to.
Yeah, I think that's. I mean, I would do it. I would try an aortogram also. I know
Yeah.
we've done those before, like going like
aortogram.
2440 or like pretty much blast that aorta and like try to see where it feels like.
Yeah.
Try to start building some relationship there. I agree, it has to be somewhere like close to
So
either the
aortogram to
suture
see
line.
if you can just close it retrograde from the
Retroaortic.
aorta.
I mean, the easiest thing would be retroaortic.
Yes.
But it's about defining the entrance, and I mean, ideally you do it in biplane, so you can see it in a couple of views, so you're not hunting around for the entrance. But a full strength aortogram would be the right move.
And Nadir, is there any chance this is LVOT? No.
No.
I don't think
Based on
so.
this image.
Based on this,
Okay.
yeah.
So is that AI? Is it regurgitating back into the LV2, or what's on the right peen? What's the color flow?
Yeah, so I think this is coming from the LV through this whatever hole and going into, this is the sac, actually the one we saw on the CT. So this thing hole is, I think, that thing I think is a sac, which we realized later. But this time I was all lost too.
Wow.
Basically, is this PVL? Is this aortic? One of the things about aortic was this is a bend towel. Like how would you leak around a bend towel from an aortic, PVL? So that's what I did not think that way. But
Well, if that's a pulsatility into that pseudoaneurysm, I would be inclined to close this. It just looks quite ominous.
and it's a big
I-
sac already.
It's a big sac, yeah.
I agree. I mean, it's going to continue growing. Once you start seeing all this pulsatile flow, it's not a small jet growing. It will continue to grow.
Right. I mean, there may be no way to access it from the inside the aorta.
Yeah.
It may be coming retrograde from the LVOT.
So where would you
right,
go?
in-
Transeptal
Yeah,
or
I mean,
transapical?
Then you have to go transapical. I think if it's LVOT, I mean, you could go transeptal. It's just quite the turn.
Yeah, was TA one of your options? Oh, it
That's
was,
what
good.
we have to discuss,
Yeah.
I think. Is it transeptal or transapical? But I chose the easier route first. I thought we could try transeptal. See, we went in transeptal. We actually tried what you did with your case. I was thinking about, the case you presented last session. That can I curve it enough to get into face towards that? So we had the agilis all the way deep, as you can see on this 3D. And basically, I tried for 3 hours with AL1, JR4, every catheter, and basically the wire was just flopping around. But the problem here was, so in this view, actually, it is right here on the top. So here, like the leak is right there. And whatever we were doing, we were coming from here. It was just very hard to wire. And maybe I tried JR4 as well, and it just nothing was so stable to go around and get into that thing.
Well, the nice
And-
thing is that this is a re-op, so going direct transapical is
Yeah.
very safe.
Yeah,
in
so
this
that's
one.
what. So we're like, we tried for 3 hours. This is not going to work. So we basically aborted.
Well, is
Yeah.
that harsh? You going to give harsh a mic?
Pigtail and maybe like an umbrella bend.
Oh, sorry.
You can cut the pigtail, the end of the pigtail, and try to make it an umbrella. That has the best curve essentially to get
So we
into
tried
those
a
spaces.
XP guide as well.
Yeah, that
with
is
the curve.
that is too big though.
Yeah,
You can
to
imagine the
basically
pigtail curve
jam
versus
it
the-
into the thing.
But like a pigtail, we have done that especially for valve and MAC cases. If you want to make the rail, you go all the way to the apex with the balloon and try to put the balloon up and try to go AV rail. That is always very challenging and difficult to turn the balloon in the apex. So what we have done also is just go in and then with the agilis and then just make a quick turn at the LVOT with a cut pigtail and then wire the run through so that you're avoiding all the cords as well, just in A to P2 region. So that's, again, these are other innovative ways to try
Yeah,
to
I think
do it.
that's a good point, and that's what we tried with a bunch of things. But the issue here is the flow that is going this way, and I think it's a very small hole right there. Hard to see on this image, but we did LV gram as well. We were there. Let's see if that shows anything different that I can figure out. This was a 20 at 40 injection. Literally, I couldn't really see where it was coming from. Let me play this again. But I couldn't tell if the LV gram really didn't help much.
I think you were there. Rutgers brought up a good point. An aortogram would have been helpful, honestly.
Yeah, I think, again, I was not thinking about aortogram because it's a Bentall.
Yeah.
So to get the valve out of the Bentall would be, talking to the surgeon would be impossible almost, unless it was a bad thing. So we were thinking it has to be something at the suture line.
Okay.
So obviously we aborted and then decided to come back next week with the transapical approach, which, I think now in retrospect, maybe this should have been our first approach. Sorry. So basically, the needle at the apex, then I put a 6 French sheath. And as you can see, we thought it would be easy now, but same issue. The sheath was right in the middle, actually. Like the sheath was up till here, but then the flow was the issue. So with the, basically whatever wire we're putting, it's just flopping around, and it would easily go through the mechanical leaflets. And I think the hole was somewhere there. I literally remember this was 7 p.m. and I told my tech, we're going to try for 10 more minutes. If it doesn't, this patient obviously has no option. But at some point you have to be lucky. So the wire did cross. And finally we,
Well, just a glide wire?
it was a glide wire through an MP, but we had tried a bunch of different catheters, JR4 to be in that area, make more stiffer. I didn't want to go beyond 6 French. You can go to 8 French transapical to pick a bigger sheath, but I think it was a flow.
Yeah.
It was just flopping around with that.
Is that an 035 glide or an 018?
This is an 018.
Yeah, so I like the 018.
Yeah.
It's a little bit easier.
So because I think it just flopped. It was
Yeah.
such a small hole that it just found
Yeah.
its way a little bit.
Yeah, because
After that,
035s, they're often, the stiffness gets in
Yeah.
the way.
It does, and it's just flopping around. I had even tried a coronary wire. We tried a run through, but
We like a coronary wires or
Yeah.
the V18s. We like
So we tried a bunch of things, and as I said, sometimes you just have to be lucky. I was like, okay, 10 more minutes at 7:15 p.m. Surgeon may have to take this patient later on. So fortunately, we were able to cross, and then I think it was put a 6 millimeter AVP2 plug, and then I'll show you the T images. Actually, it was right where I thought the hole was, and it basically completely shut it down. And there was a mild, trivial PVL or something.
So no leaflet impingement or anything.
No, so we had, as you can see
Wow.
on this previous image, the leaflets were working fine. Sorry. And that's why I chose the 6, because I didn't want to put a big plug in with the discs on the LV side that it will just interact with the leaflets. So
You also didn't have an anchor wire, so you're pretty confident.
we said, that's it. As I said, it was 3 hours of, even after transapical, we thought, this will be easy peasy, we'll cross, put a plug in, we'll come out. But after like 2.5 hours, the wire, it was just such a small neck that anything was just, we're like, we're just going to try one plug. If it works, it works. Otherwise, whatever.
But if you were to do an anchor, so this is six French sheath?
6 French sheath and a
Yeah,
6
so
French
you
multi in it.
Yeah, you
Yeah.
could easily have an anchor wire in
Yeah.
there with a small device.
You can even just leave a coronary wire
Yeah.
if you wanted to. Just anything so you didn't have to rewire this.
Yeah, I think it was probably, usually we do for all the PVLs or everything else. But I think in this case, it was just one of those, once the plug came out, it was like, okay, we're done now. A lot of tugging to make sure, it was anchored.
How did you close the apex?
We're getting there. Sorry. So again, I thought, let's go home now. It's 7 p.m. But then I realized, we have the plug, the hole to close. So first I did a LV gram through the pigtail to see where our base of the LV is or myocardium is. Here I did put a safety wire, and then again we put a 6 AVP2. And I do what Jed Rihal taught me. We did a little bit of puff into the sheath to look where the myocardium is, a little puff in the myocardium, and then release the plug. So that part was actually, and you can see the valve working well still.
When you initially got access, what kind of imaging did you use to get access?
Basically, we went to the apex on a T. We just saw that RV apical, but I'll show you we were not.
Yeah, 'cause
we
that can
thought
be-
we were apical, but
And sometimes fluoro helps too, or even a surface echo.
yeah.
Right.
So we had T, and we thought we were, and we actually had the probe as well to see if I'm right
Yeah.
at the apex. But that's when I realized in this case, sometimes you think you are right into the apex, but you're not. The other thing I realized is, and I think I may have learned this before, is you don't want the sheath to crater, the myocardium. So basically, we had one person holding the 6 French sheath throughout the time, because every time the guides are coming out and in, you don't want the sheath to just keep going in and out, because then you will have a myocardial hematoma as well. So the one person was basically just fixing the sheath while we were doing all of this, especially if it was not very stable. So this is the follow-up CT at 1 month, and we can actually see, this is the plug right there, and the pseudoaneurysm is gone. There is no more sac, and again, I tried to find the sac. I couldn't, so I asked Jeff to again get me some images. But you can see it's completely on the side, so it was probably suture line. And then this is where we were on the apex. We were not. So on the short axis, if you see, we were actually almost at the lateral wall. It still closed pretty well. There was no pericardial effusion at any time, but this was not the true apex.
Good, you missed the LA day.
Yeah. At least when we did transapicals at Mayo, Jerry always said LAD never comes to the apex. Actually, it comes to the side around it. So that's why we want to be at the apex. So we were fortunate here. We didn't touch anything. But yeah, so overall, I think the learnings were, I probably would go next time, just go transapical directly if I knew where the angles are, and always have a plan B, C, or D if A doesn't work, rather than keep trying and cause an injury. And taking percutaneous transapical can be performed successfully. Thank you.
That's an awesome case. Yeah. I have a question, if that's okay, Jason. I would have done this just slightly differently. So, did you think about using a 5 French sheath and not closing the apex?
I think I've always closed it. 4 French is where I've not closed it when we sometimes have to do a hemodynamic study. So, and I did not think 4 French would be enough for our plug. We need the stability as well. So anything above 4 French, always close it.
You can get a 6 AVP2 through a 4 French flexor.
No, I was talking about the pseudoaneurysm closure because I was not sure if I just use a 4 French will be enough to.
Oh, that's what I'm saying. A 4 French flexor, if you use that through the pseudoaneurysm, you can put a 6 millimeter AVP2. And that's what you put was a 6.
And
so
then just close it.
Yeah. But I think if you're going to go without closure, you really do have to be careful what needles you use. So if you're going to do the micropuncture, you need to have a loaded wire because you need a stylet. That's a historical teaching. The Brock needles all had stylets, whereas most of our needles, I don't even know if there's a Brock needle anymore. Do you? Is that what you were talking about? Do you use a Brock needle for this?
Just a micropuncture needle.
Micropuncture? Yeah. I get a little concerned because of the coring. Yeah. So I mean, it's probably small, but theoretically, it's you're having a stylet in the micropuncture would be.
Yeah, that's a good point.
Yeah.
But nobody's done. I don't think anybody's done 100 of these, but the several that I've done with the 5 French sheath, I didn't close and had no problems with.
The 5 French is usually okay.
Yeah, I mean, the real challenge was just wiring it. It was, and you have, everything's moving in a different direction. So your apical sheath is moving with the LV, then the LV pumping around, and then the valve itself is moving independently. So how you navigate all that, it's very difficult, right? So ultimately, and sometimes like a curve on the wire works against you, like the pre-shaped wire, it's better to go just with the straight wire. Ultimately, was that a straight Terumo that you used, or did it have a pre-shaped?
Yeah, I think one of the biggest challenges here was we didn't know where the hole was on fluoro. Yeah. As we did LV gram, we did everything, and we just couldn't figure it out. So we were having biplane would have probably helped a little bit. Yeah. But ultimately, it was a multi-purpose 5 French diagnostic catheter jammed into that side in a soft wire.
The only other thought I had was to use a buddy wire to stabilize your apical sheath while you're wiring. So somehow get a second wire either through the valve and just kind of hope it doesn't get caught, but just to stabilize or maybe even into the LA, that it kind of holds your sheath now stable, and then you can kind of use that, because I see the challenge. Everything's moving, and it's maddening. Yeah.
Jason, as you're talking about it, I'm thinking putting a Safari in the LA to stabilize the sheath and then use everything else parallel to it to wire something. But coming to one this is very fundamental, and then Nadira can comment on it. But it's very important just for all mitral procedures or any of that to have a good intercommissural view. That's where the apex is, because you can show apex in every view of the heart. And just as you had a lateral puncture, thinking you are apical puncture, I think it's your sonographer's fault.
No, I was holding the probe, but I think, as you said, we are foreshortened sometimes.
Yeah, it is, exactly. So it's very important to have a good intercommissural view and then biplane that to get the true apex. We did a lot of these when we used to do apical intrepids, and we used to do it and then get a good view, and we used to think that it's a good view, and then we used to poke with the hand. Probably Paul remembers those
sometimes
days.
The rib is right over the apex, and you can't access it, so you're a bit at the mercy of the patient's anatomy.
I actually think that lateral puncture might have helped you.
Yeah, I think so too. I think the angle was
right
better.
There. I think if you gone true apex, you might not have been able to find that curve.
No, I think it would not.
Better to be lucky.
sometimes you just, sometimes even wiring, we were literally 2.5 hours into wiring. It was 7 p.m. in the hybrid OR, and everybody was tired. And like, how long are we continue? We will keep going. And surgeon was there too. Like, in case I have a hematoma in the apex, like he was ready to help with that part too. We had discussed if we need a bigger sheath, I may have him do a transapical 11 French sheath and then go that way. But
Hey,
That's
Kashish,
great.
did your tech
I think-
volunteer to wire as well? Did your tech volunteer to wire as well? Give it a shot.
I think it was like a CTO card on the back.
All right.
Lots of wires.
In the interest of time, we should move on to the next case. Yashasvi Chugh is going to present complex transcatheter defect therapy. Plug sandwich.
Thank you so much, Dr. Sorajja, for having me. All right, so this is an 80-year-old. She's had 2 prior sternotomies. She's probably the only person I've seen with a mechanical tricuspid valve and mitral valve, which was placed about 20 years ago. And she was referred for transfusion-dependent hemolytic anemia, shortness of breath. She was basically being transfused twice a month and had come to see us. So as part of our evaluation, I'll show you the echo in a second. So this was a CT. As you can see, this sort of ginormous crater posteriorly, which measured about 16 by 6 millimeters, which was the only culprit we could see for her hemolysis and sort of this heart failure picture. This was the TEE. So as you can see, really big posterior jet. There's pulmonary vein flow reversal. So it's interesting. She was I would have thought she was only going to have heart failure from a severe MR, but she was hemolyzing, and she was also in class 3, class 4 heart failure. Pretty miserable. So the clinical challenge is, she's 82, 2 prior sternotomies. Both her valves are functioning fine. She's going to be high risk for a 3rd sternotomy, or we attempt a complex PVL closure. A couple of things that were an issue here was, there's a large leak. I didn't show this, but I'll show this in a second. She had a pretty calcified septum as well. So, a couple of options: transapical, you go transeptal antegrade, or you try retrograde down the aorta and see if you get lucky. So maybe I'll stop here and see what you guys would. How would you approach this?
Process, how would you do this?
The first thing I would look at the septum, right? Most likely when the surgeon did the mechanical, they went like a right atrial approach, and they repaired the septum afterwards. So I would see how calcified it is. Can you safely balloon it or not? If you can safely balloon it and put a large sheath in, then my approach would be go transeptal and try to cross it. If that's not an option, then I think my second would be transapical. I'm not a big fan of the retrograde aorta just because there's too many bends to navigate, and you need all the stability you can get in those cases. And having said that, I know people have done it retro. So
all right, so see what we did. Sorry.
The other thing is even if you can get the sheath in, can you cross, and do you have enough backup support? So always thinking about a rail in the end, and the fact that she does not have a mechanical aortic valve helps you.
Yeah.
Now you can cross the aortic valve and snare a loop wire if you have to, a rail wire. So that brings in some options. Probably you'd be able to do this transeptal.
Okay. And then 1 plug, 2 plug. How do you size your plugs? Do you do sequential plugs, 2 at the same time?
I would go at least 3 hopscotch technique. You'll need to make sure you move your wire. It's a big hole. I'll be shocked if just 1 plug can cover everything. You need to make sure your disc doesn't overlap with your mechanical valve there. So you can use a really big device and overhang too much on the mechanical valve. So I would definitely be
Yeah, I think a single device is too much risk of prosthetic leaflet impingement.
rail is actually a great idea, especially if you're talking about multiple plugs.
Wow, look at that calcified septum.
Yeah, so septum was actually really quite calcified. We got through with a C0 Bailey. So our setup here was GA-TE. We've also moved to biplane fluoro, just I think speeds up the case. A large bore venous access, so 24 French dry seal, and then a 10 French sheath in the left femoral artery. I was also anticipating multiple wires, multiple rails. We went ahead, did our transeptal, and it wasn't very hard to cross. We had a nice RAO angle, which was also from CT. We crossed with mother-daughter technique with a glide wire. And just anticipating the position, I actually went ahead and just snared, made an AV rail. And I thought I'll get lucky, one AVP2, and you should be going home after that. So put in an 18 millimeter AVP2. Of course, leaflets are impinged, gradients high. There's still a lot of leak around this. So then we went ahead and took this out. It was an 18 AVP.
And then just tell us what do you have across the defect there? Is that a shuttle sheath or?
Yeah. So
yeah. What
I
size?
6 French shuttle.
6, good.
Yeah. So as you could see, I maintained my wire. Sorry, I was able to maintain my wire. I have an algorithm where I have a paper from Mayo where it's an angle glide, soft angle glide, 6 French sheath, shuttle sheath, and then an 18 AVP, and all of that is there was no issue. I could maintain my rail throughout when I was doing this deployment. So did that didn't work. This was unsatisfactory. A lot of residual MR. So then we said, okay, let's go ahead and create a second rail, but we couldn't get anything through the septum. So we were able to get a wire into the into the LA. We ballooned with a peripheral balloon. And then basically I put a MP guide through the shuttle sheath, created a second rail. As you can see here, I'm ready with my gooseneck. Created a second rail. And then I put 2 6 shuttle sheets across the defect. And this time we went with a 12 and 10 AVP, sort of deployed simultaneously. Again, didn't really sit right. Our gradient shot up. You can kind of see the 3D picture right in the middle. One of the leaflets doesn't open as well with this approach. So sorry. So as you can see on the left, I'm trying to see if I can, maybe get more coaxial. So I do this a few times to try and maybe pull the belly of the device higher up so I can actually get into the leak a little bit better. It just doesn't work out. So, and this is, sorry, I take that back. So this was now an 8 and 10 plug that we tried because the 10 and 12 didn't work. So now if you focus on the picture on the right, so I'm doing my deployment and one of the plugs, of course, gets deployed on its own. So now we've got 2 rails. We've got 1 plug that's deployed and another plug that's attached. So the one that got deployed was a 10 plug. So, life gives you lemons. We obviously left that behind. Now we have no choice. I resheath. Fortunately, I still have 2 rails. So I resheath the 8 plug. And now, if you look at the picture on the left, sorry, this is playing very slowly. Sorry about this. So if you look at the picture on the left, so I have a 1 plug that's deployed. I've got 2 wires. Now I've got 2 shuttle sheets basically across the defect. And now I'm sandwiching 2 more tiny plugs just next to the one that was, unfortunately deployed on its own. And sorry, this is sort of what we were left with. So we've got 3 plugs there. On 3D, you can't really see the second plug. It's basically squished between the first 2. And we were ultimately left with an 8, a 10, and a 10 sandwiched. Fortunately, leaflets are moving pretty well. Gradients were pretty good. And we were able to abolish the leak completely here. So she did very well, actually, after this. Hemolysis stopped, went from class 3, 4 to class 2. And I think real take-home point is if you can, again, large leak, probably need multiple rails up front, not a bad idea. It's a good idea to have large bore sheets in both the veins and the arteries, and often deploying them simultaneously versus sequentially could kind of help them sort of stack against each other.
So her hemolysis, what happened?
Hemolysis stopped actually. She
Resolved.
hasn't been transfused. It's been about 6 months, and she
Yeah.
feels very good.
I think one of the things about these mechanical valves is the hinge point is where you can put a bigger plug, and as you go around the hinge point, that's where the interaction happens. So, usually a 12 will work where it's exactly closing right in the center, but as you go around the curve, you have to go to 8 or 10s because that's when the leaflets, and I think that's what happened with the 18.
Yeah.
It's too big, but great result.
I love this case. So so with hemolysis, you do have to get a perfect result because otherwise anything left behind, the hemolysis is just gonna continue. But I like this simultaneous deployment because when I've done it sequentially, which is honestly my lazy way of doing it, one at a time, which is a little bit easier, I've been disappointed because you can't control where they go. And sometimes you end up with a leak on the opposite side of where your anchor wire is, and that's frustrating. So then you have to like either rewire or take everything out and start over. So, but the sequential is really nice. What do you think happened with that first plug deploying inadvertently?
I think we unsheathed, resheathed 4 times, and
It just twisted off.
yeah, I think we in that manner just twisted off. And
Better lucky than good.
Yeah, I also like doing simultaneous deployment too. If it's big, just put 2 in at the same time, and then you see how they relate to one another. But the challenge of the mechanical leaflet is always, right? That's always the real challenge of these because you get a perfect result and then the leaflet's not moving. So we've sometimes had to convert to AVP4, and it has doesn't have that disc on the one side. It kind of tapers with the Hershey's Kiss shape, so that can help you sometimes. Put 2 4 side by side, but it's a lot of trial and error with these cases. You did a great job just working through it.
I was thinking
find the AVP4s they're hard to land for me. I can't quite know where to put one disc relative to the other. Whereas these AVP2s, you just pull until you get to the end. I don't know how do you guys have the similar experience or?
I've fished out too many AVP4s and iliacs and splenic arteries to want to use them anymore. I think they embolize, and it might be because I don't know how to deploy them, but they.
I think it's how I feel.
Yeah.
The only
They don't have a
AVP4s I've
nice
used
waist,
are Tab or like Sapien in a ring, and then there is something that I know it will anchor around it. Other than that, it just doesn't feel comfortable. When are we getting AVP3s for this?
Hopefully that trial's done soon.
I mean, at least for the trial study, they don't allow multiple devices. So
Yeah.
that's the other thing. Like, so you got one of the criteria is actually when you pre-plan, you should say that you're able to close it. They will allow if it's an emergent, like you put the one in, there's still residual, they're not going to stop it. But this hole would never have made AVP3 criteria because it was too broad for the study.
Okay. Great. Thanks so much, Yash. Fantastic. Harsh, it looks like you're up next. More holes and plugs.
Yeah, I don't think so. I have that of an interesting case, but let's see what you guys think. All right, so these are my disclosures. So 65-year-old male, history of surgical aortic valve replacement with a 26 millimeter aortic homograft and a mitral valve debridement surgery for aortic and mitral endocarditis in 2007. In 2012, he developed homograft stenosis, severe MR. He underwent redo surgical aortic valve replacement with a mechanical valve, and he underwent a primarily commissural, not commissural, on the A1P1 side, Alfieri stitch at the lateral commissure without a ring. And stable since 2020 until 2020 when he started having more NYHA class 3 symptoms and increasing diuretic requirements and holosystolic murmur. So this is the echo. You can see the severe MR centrally, and you can see the Alfieri stitch, and then you can see the leak next to it. So this is again.
So the Alfieri stitch was 3?
It
Was that harsh?
It was
Oh.
lateral, yeah.
Okay.
It was lateral.
The
A1,
so it's a lateral one,
A1,
and,
P1,
and then the PVL is lateral to it.
There's, well, yes. I mean, it's still leaflet, but you may call it a PVL.
So,
Oh, sorry. Yeah.
yeah, no, no,
It's
I'm a
still
little
a
confused,
leaflet,
but
yeah.
so there's the Alfieri and there's a jet on either side of it.
Either side of it,
Okay.
yes.
Okay.
So there's an A2P2 central MR, and then there's a jet next to the more lateral to A1 P1 stitch. So
Which is unusual. I mean, usually if a surgeon's going to do they'll just close the whole commissure off.
yeah,
So
they
you
did not.
wonder if, in the original surgery, did they actually close the whole lateral commissure, or was it literally a focal edge to edge?
Yeah,
It was probably done for SAM though, right? It wasn't for MR.
it was for MR.
It was for MR.
was
So it's
for
an
MR.
Alfieri for MR.
MR, yeah, primary only.
Huh.
So the clinical challenge is 2 open heart surgery, including post-homograft, and high-risk surgical candidate. So, and transcatheter mitral valve replacement is not possible because of repair, and of course would not get into any clinical trials as well. So, what are the options here? Anyone?
Well, so we've put plugs around clips, and so I gotta believe you can put a plug around an Alfieri stitch. But the
And the
issue is gonna
annulus.
be in the commissures. You don't. Well, I'll let others speak. My experience of plugs near clips in the commissures has not always been great because the corners of the valve can be a little bit difficult to judge in terms of the sealing. So I don't know. Others?
Actually, yeah, we've done about 10 of these, not these, but plugs with clips. And actually, I find the commissural the easiest. What we do is we do a 3D sizing, and we go with the largest size. And usually it's a 16 or an 18 plug. But, follow-up is not the best. And so I just saw a patient 3 years out and now has a leak around the plug, which is unusual. But yeah, I think in this case, if the gradient is fine, I would size it on CT or 3DT and try to put a big plug in the commissure and see what happens.
Yeah, the other thing is, can you just put a clip in there in the commissure? I mean,
Yeah.
that would be, I
Yeah.
would say, your first, that should be
Well,
your
I'm sure
first
a clip.
strategy.
Right?
Well,
You're talking about more
yeah,
of a
the nice thing
commissural
about that
clip
is that
first.
you go there first and you don't like it,
Yeah.
then you put a plug between the clip and the Alfieri.
Yeah.
And it's you have a pair of goalposts.
Yeah.
I mean, these clubs, these plugs post-clip have not done that well, generally speaking. I mean, nobody's very excited about that. And the literature shows they embolize, they can go down coronaries, there's a lot of leak and a lot of hemolysis. So, I mean, we also explored doing it, but the best thing is to just put a clip in if you can.
Yeah.
No, I think it's always a bailout. Like if you can't put a clip
Right.
and you're
Yeah.
stuck and there's no leaflet, that's the only time I would do it.
I mean, those are all great points, and we would do that. But the name of the talk is plugs and leaks and closures, so I think we have to go with that theme. So basically, we plan for edge-to-edge repair with the mitral clip and closure of the lateral commissure jet, essentially with the plug. And it was pretty easy, actually, I'd say. Of course, it's a lateral commissure. Wiring is always easy, and a Gillis and a regular microcatheter, and it was an angled glide cath. And we were able to cross, and we put a 12 millimeter, if I remember, 12 millimeter plug in the commissure, and it went pretty good. The leak completely closed, and then we cleaned it up with a mitral clip.
Wait, so you
guess
did the
why
clip
did you
after? You
just-
did the
yeah.
clip after?
Why did
Yeah.
you?
On the other side of the Alfieri. That,
On
But
the
what
other
if the
side.
disc kind of overrides then where you want to? I mean, how did you decide what sequence to do?
Well, I think we went back and forth. I think you can go either way. I mean, I don't think so anyone knows the correct answer. You can go first clip and then plug. It can go either way. I don't think so there's any particular way.
I mean,
you
I
can-
would have said clip first
Yeah.
because it would have been, in case you can't see the leaflets for
Yeah.
grasping or
Yeah.
the plug interferes with the leaflets for
Yeah.
grasping.
The other counter argument is you put a clip in and now you're pushing and pulling in the commissure. You can rip off the leaflet from the clip. It's a fresh clip, and
Yeah,
those are
that has happened to me too.
Yeah.
With plugs. after
exactly.
clips,
Yeah. I mean, so it can. No one knows the right answer, but I think we felt that. Let's see how this goes.
In an XT, it looks like wow.
Yeah, that was
Go
20.
big or go home.
Yeah. And it was pretty good result actually. And this was the 30-day echo. Patient is doing great and no issues.
Would you have done it in that sequence, Jason?
I think you're right. It could be either way. I mean, it seemed like they're fairly distant. Was this before XTW?
It was before
Yeah, so G3.
in 2020.
My other question would be like, gradient, excellent grade.
Yeah.
You have an alpha area already. You're
Yeah.
closing the one commission. You're putting a clip
Yeah.
really on your
Yeah.
so you're targeting all three.
Yeah.
I mean,
I think NTW would have been more like this time right now. At that time, it was NT and XT. I think NT would have been too small, so it's more like a functional MR as well in the center. So
What gradient? Did you have a gradient afterwards?
6.
6.
Yeah.
From a gradient standpoint, this approach actually may be better, right?
Right.
Because if you put a clip,
And you have higher
then you're,
gradient.
like gradient is 5, then
then
like what
you-
do I do?
yeah.
Although most of the time with the plugs I've done with clips, gradient doesn't change, but here at least you knew that gradient is fine. I can put.
Yeah, and the other approach. I mean, we're not specifically done it for alveolar stitch, but we have closed the commissures next to, for example, a ring which has dehisced actually, and then you have the ring dehiscence from the lateral commissure, and there's a leak in the lateral commissure. You've gone around it and tried to put a clip in through there and seal the commissure. This case particularly, we felt that AVP2 was better rather than putting 2 clips, one next to it. And also the space was tight. A 12 millimeter plug, as you can see, it's completely sealed it. So, or 10 millimeter plug. So the space to get the clip in, clip out, we probably can do an NT, I think. NT or a P5 would work fine. But that was 2020 as well. So, okay, thank you.
That was a great case. What a great result for that patient, too. Our next presentation is by Samer Abbas, Ultimate Structural Case. When and how I close this defect.
Thank you again for having me. Actually, these are great cases. I have a simple case, but when my assistant told me that Paul wants you to last few weeks, we said do you have a structural case about closure? I said yes, I do. I was excited because I was about to change the way I practice and said let me just present this and then I decide if I'm going to change based on what you guys tell me. So this happened to me now in the last, I will say, 3rd time in the last 6 weeks. Okay, so this is very fresh. These are my disclosure. Obviously, as an introduction, we have structural cases for TMVR, TAVR, Watchman, all these common defects as we see about PVL and ASDs. And transcatheter approach is a preferred way to close them. Whether ASDs, PVL, after TAVR, residual shunts, VSDs, we saw all this. And pseudoaneurysms, by the way, they were very good cases today so far. So when do we close? We all know that. Hemodynamic unstable, RV dilatation, hypoxia, hemolysis as we see heart failure symptoms or persistent symptoms despite medical therapy. So the way I learned, or in the last 15 years, I'm very conservative financially, etc. But let's see what you guys think, especially the panels. The devices we all seen, the implants, the AVP, the occlusive, the cardioform, the implanter, those are usually what we use. So this is a 75-year-old female, has severe symptomatic aortic stenosis, mitral regurgitation, severe pulmonary hypertension, severe TR. I did a Watchman on her long time ago, and she also has a pacemaker. She's on home to require 2 liters. She comes in with a heart failure symptoms. She has, as you see, severe MR. And we decided to basically go ahead and treat this percutaneously. And we did a tear repair with a Pascal. Patient did very well. And catheters out. And these are the final image of the septum. I left it, obviously, this is what we do. And I went into a 3 days vacation. I came back, and the patient's still in the hospital. Now, patient is short of breath, on home O2, desaturated, required 8 liters now, and she's almost shocking. Urine output is, and I this is when I learned that I need a partner actually in a structural guy in my group, because like I go on vacation for like a 3-4 days, this patient sitting on the floor, like requiring home like 8 liters of oxygen and hypoxic, and no one like think, oh, this may be part of like the procedures, you know? So I said, well, let's do an echo just to make sure my tear is okay first.
The bold move, getting an echo.
Right. So
You could have ordered that on vacation.
it was a golf vacation, and I was focusing on a lot of things, but not my work anyway. So I'm struggling with my golf swing these days. That's why, you know.
Gets better.
Right. So anyway, we get an echo. I think this is a decent results, but this is what I'm dealing with now, right? And obviously, we have a septal defect from my transeptal access. And I'll tell you, there is a lot of procedures as an interventionalist we do that they're very satisfying. This was one of the most, incredible. Obviously, closing this was not that complicated. We use both a implanter or cardiofirm. The hole is there, so obviously wire and catheters. I did a 30 millimeters cardiofirm, and we do this under ice most of the time, not a TEE. And cross with the sheath, obviously. Depends on the size. Not all the time I do balloon sizing, but if the septal is like destroyed and like it's big, we will size it with the balloon. Self-expand, obviously, most of the time under ice, but you can use it with TEE. Success rate for this, obviously, over 90%. I'll tell you, I put that closure within like few hours. Improvement like significant, like she got so much better, and she went home obviously within about 24 hours on home O2 2 liters, as she did very well. She's still doing well. So in conclusion, and because this is important, like timing, and the question for the panel here, I leave everything. I leave unless there is a significant hemodynamic change on the table, which happened, like they became hypoxic or something like that, we'll close them. But all my Watchman cases, TMVR, valve, all of them, I leave them. But this is the third case within 6 weeks that I have to bring them back and plug it. And I am about to say, maybe I am actually need to change my practice where I should plug them on the way out and done with it. And I heard there's a lot of centers, they plug everything. Like, it's like a common practice, is not rare. In this case, the idea until now, I will say, we plan it case by case, but the fact that this is happening to me 3 times now within 6 weeks, I'd like to know your opinion about closure of those septums with this, especially with the transseptal approach that's becoming the favorite for mitral repair or all these like transcatheters approach. And thank you.
Great case. No, that was a great illustration of, in the registry, in the ACC registry, it's about 5% of TEER cases undergo closure. So it is not every patient, but there are patients, and we published on like what are the things and that you might close. So this patient may have been predictable that this would have happened. You said the patient had severe pulmonary hypertension.
Severe pulmonary hypertension, yes.
So, and in addition to the severe TR, you showed us a single frame shot of a left to right shunt, but probably it was bidirectional.
Bidirectional, yes.
And so sort of maybe doing a right heart cath in those patients beforehand, but that would be one of the indications for closure, right? She's already compromised on home oxygen. She's got a propensity to have a right to left shunt with her right-sided heart failure. Probably, we would have closed that one just preemptively, but you never know, right? Sometimes they do fine. But yeah, you're right. I don't think everyone needs to be closed, but some should be closed.
Sure, but I heard there are some centers that basically they close everything.
We don't
TMVR, right? Yeah.
For TEER
not for
or
TEER.
for, because other mitral interventions maybe, but I think TEER, I don't know too many who are closing all for TEERs.
I certainly think it's more than it used to be. And the first TVT I showed is actually 2%. Yeah, and so, but if you look at TVT, a quarter of the patients who have M-TEER have severe TR.
Sure.
So the majority of patients who have severe right-sided disease actually are not being closed. But I do think that we become more aggressive in terms of closure because we're worried about making the TR worse, and also this issue of bidirectional shunting. I mean, Nadir, what are our criteria for closing? What do you think?
No, this is a great case. I think it's just a classic example. I think from an imaging perspective, I think we imagers, before taking out, I think it's really good practice, at which Paul and Voudris always does it in our center, just checking the dira, check the septum.
Right.
Once you take out and the color Doppler, and I always pulse it, and you can see, because in your case, I'm pretty sure the septum will be bouncing, high right atrial pressure. Those were like red flags.
Right.
That the next thing these guys will say, all right, just bring in the cardioform. Or even before the case as well. And always get your imager to check the tricuspid valve. The TR jet, sometimes you can see the TR jet just hitting on that septum, and you know that it's going to be a bidirectional
Right.
shunt.
Right.
Yeah, so these are the key flags that I think in our, especially we are seeing a lot of both MR and TR cases at the same time. And the other thing to point out is during the imaging, once you close that septum, just get your imager to image the tricuspid to see the possible views, because once you close that ASD, the iatrogenic ASD, it can be quite challenging in terms of imaging the tricuspid for a triclip. But so just to preempt what's the next step, right, for the patient in terms of your treatment plan. So always do, that's what we always do.
Yeah, we've had a couple of cases, Nadir's right, where we close the septum, and frustratingly, we close it because we want to be able to keep the TR from getting worse and bring them back. But then we find out the imaging acoustic windows are not as good afterwards, especially with an ASO. So my question to you guys, ASO or cardioform when you have these with M-tier? Harsh, I want to ask you, what do you use?
Cardioform. I think the
Cardioform?
theoretical possibility, the practical possibility of going in is easier.
Recrossing and
cardioform,
such?
yeah.
Causes?
But again, I think
Sorry.
just a comment. I think it's important to understand what are the RA pressures. I mean, you reduce the LA pressure to probably VVA up to 15, then you have an RA pressure of 20. It is going to be bidirectional, and that needs to be taken care of. We also get the patient saturations to 21% normal oxygen, and see what happens to the to the shunt process at that time as well in terms of oxygen saturation. Those are the things we do before you
conclude
That's
the
a great
case.
point.
Yeah.
I mean, we at the close of the case, right, the guide's in the LA, we get a final LA pressure. We pull the guide back into the right atrium and get a final RA pressure through the guide. So you don't even need to do a right heart cath.
Of course.
So then that just gives you an instant.
That's great. That's great. I think. All right. Thank you so much. Appreciate you guys.
Great. Thank you. Ricciardi? It is you.
The clicker.
You got that advancer?
Mark Ricciardi is
Still
one of the he's one of the OGs.
So I had a very similar case to yours, that he was a lunger, and he was from out of town.
A lunger. What's a lunger?
Sorry, COPD.
It's, okay. Sounded
You
like
guys don't
bait.
call it
Sounded
that?
like bait for.
Did he have the high blood and sugar too?
And he presented with cyanosis to his referring guys, and they just called out of courtesy, say, yeah, thanks for clipping this guy, but he's gonna die. And I'm like, can you just transfer him back to us? And sure enough, he was blue, cyanotic, and he had a COPD exacerbation. They were right about that, but he started to right to left shunt with the COPD exacerbation. So anyway, so it's funny. All of these cases, I was trying to think of what to present, and I actually have a not great case, but all of the cases I thought about have been presented already. So I wanted to just do something a little bit different, and this is maybe brings out my inner coronary operator, which I can't seem to shake. So it's an 82-year-old guy, and I don't want you to think too much about this first or two lines here, because it may be a bit of a red herring, but he presented to us because he had this laparoscopic diaphragmatic hernia repair and had continuous blood coming out of his chest tube, so they got a CT. And he had known angina, interestingly, before this, despite having no CKD. And here's the CT. I don't read CTs, but I think it's pretty obvious. You can probably see that there's this aneurysm that was called on the CT. And if you can see on this movie, it appears to be coming from the right coronary artery. Here, I'll show you better than me. But go back and then go forward again. Left, hard to see the right. There's a clear communication. So this is just a, yeah. And I tried to freeze that too. And so that's what we got.
So this guy had a robotic. Did they get a CT? I mean, is this the first CT he ever had in his life? Or?
Exactly. Right. So, and so my first thought is like, wow, how did they do that during this robotic surgery that had just happened? It's big and leaking in his chest and chest tube. I really think it was a red herring, but maybe not. Maybe I'm just not smart enough to figure it out. But I did go back and look at a CT. CT report said nothing about anything like this. But I went back 6 months prior, and there was a smaller version of this there already. He had never had a coronary intervention. He had a cath, but no coronary intervention. And then, I don't know, this doesn't, I just figured I'd show this because I knew Nadira would be here, but I think we're just seeing this mass, right?
History of chest trauma, car accident, get kicked in the chest by a horse.
Yeah. What was the last one?
Kicked in the chest by a horse.
Okay, all right.
We had a patient once that got.
They don't have horses in Chicago.
Some of the cops do, but they usually,
Right.
cops kick them themselves. They don't let the horse do it. But, so, and here, of course, you got an angiogram. And this is what we see. You can see this large mass. Obviously, contrast is spilling into it. And very calcified distal right, you see that. But seems to be filling a little bit, I think, although the CT suggested there was no filling of the distal right, no collaterals. So this is, so, you know, what do you do about this? I think we could just decide to treat this medically. I really don't think this had anything to do with this continuous blood coming out of his chest tube, but maybe they nicked something and it is a big mass. But it was pre-existing if they did. I don't think, like I said, on that CT already. So, and here are options. Go to surgery, of course. He already knows the surgeons. Coil embolization, probably, I mean, it's impossible, right? You can't even think about it.
$400,000 worth of coils.
That's a good point. But you could stick some other stuff in there. Kitchen sinks.
But I guess the question is, do you think he needs his right coronary artery? Because it looks like it does it just empty into that pseudoaneurysm?
Keep on going?
Huh?
Keep on going with your thought process?
Well,
What
I'm
do you
just
mean, does
saying
he
if you
need it?
don't need the right coronary artery, if it's going nowhere.
Okay, so
you just
I
coil
totally,
it. Just coil it,
yep, took me a second. Sorry, Paul.
I mean, that-
But because the CT scan,
it was a late night, I know.
I crashed. Yeah.
Because I can't tell where that coronary artery is going.
Right.
It doesn't look like it's going anywhere.
Right. So the CT said this right coronary artery is closed.
Closed.
Yeah.
Okay.
But what do you think about this angiogram, though?
You see filling.
Is a filling down.
Is that just calcium? Or do you think a little contrast is entering that distal right?
It's almost like a giant pseudoaneurysm connecting the proximal and distal ends of your right coronary artery.
Yeah,
Right.
I mean, it's also possible it's a AV fistula, right? That it's connected to the coronary sinus there. That is the coronary sinus we're seeing there, maybe, or some
Yeah.
posterior vein or something. I mean,
Okay.
Well, that's the question. Is it the distal? Is it into the fistula, into the coronary sinus, or is it actually the distal right coronary artery?
yeah, don't know.
Yeah. Well, I think I know, but I didn't know from this. So I did think that there was flow into that right coronary. The inferior wall did move, and there are no collaterals in the left injection. So I just assumed that this was an important right coronary. So the issues were, I think, pretty clear. You got to do a covered stent here. It's a very large bed, I think. That looked like a big calcified right. And then, you know, how do you wire this thing?
So you're talking about connecting the proximal and distal ends of the covered stent? Ah, sweet.
Yeah.
So that's essentially a interventionalist bypass.
Yeah.
Yeah.
Yeah. And then I think I would do this differently if I had to do it again, but we thought about the lengths, because that Jason was talking about, you need a really long, very long device, which in retrospect I maybe would have tried to find a very long device. We all know what device I'm thinking about, Viabon. but I thought I'd use coronary covered stents instead. And the next question is, well, how do you do this? First you got to wire it, and then, well, let me ask, well, how would you do this? I'm sending this case to you. How would you do it?
It's an interesting point, right? I mean, wiring is definitely going to be challenging, but I would prefer a self-expanding Viabahn 100 centimeter stent. The reason is the distal vessel has become more and more aneurysmal and bigger, as you can see from the picture. Once you're able to wire it, you can IVUS it for sizing as well. I think that is a good way to do
Always.
it. And then probably use a self-expanding because the proximal vessel is small, and then cover it all.
Yeah, yeah,
Wiring is going to be the biggest problem in this case.
yeah.
I agree. Once you wire, I was saying, it can give you length, it can give distal edge, like edge.
Yep.
And
Well, we're talking about sending a guide through the proximal to the distal,
Yeah,
wiring it there, and then bringing your guide back out.
yeah.
And sending everything over. So,
So what
it'd
if
have to
you-
be it'd have to be at least a 7 or 8 French guide
Right,
for support, and use a Grand Slam or something really stiff,
right, exactly.
and then choices Viabahns or something else. So
Yeah, so what if you didn't use a
Even an
Viabahn?
08 wire, I've used an SV. I've used V18 wires in the coronary
V18.
for that.
Yep,
Basically,
that's a
and
good
so
point.
those are-
Yep. So what if we didn't have a Viabahn? What if you want to use Pyrus stents? In other words, limited lengths.
yeah, but you have to stack them
Yeah,
Yeah, you kind of,
and pray you
Snorkel
don't,
'em
pray you don't
one
lose
after
wire
another.
position. 'Cause
Right.
if you lose your wire, you're gonna be really screwed.
and would you go distal to proximal, proximal to distal, or it doesn't matter?
probably proximal to distal, because that would make the most sense
Actually,
for
that
the way
would
it,
be- yeah.
so you're not crossing through the,
And actually, that would be more forgiving if you lost your wire position, because then you wouldn't
Yeah.
have to wire the distal part.
I would go distal to proximal like normally. But
You go distal to proximal.
like at least have half of the stent in the vessel distally,
Mm-hmm.
and then you have hanging half, and then you have to just stack
Right.
them up.
Yeah.
But yeah, with the length, it's an issue.
How would you do this case, dear?
Where's my surgeon?
So, yeah.
at that point, your IVUS should be showing you. It would be able to show you that, right?
Yeah.
Because you'll see
Yeah.
like
Yep,
the size
Yeah.
of the pseudoaneurysm
that's a great point.
just blow up.
I don't think that was what's going on, but, I didn't save the IVUS for this presentation, but, all right, so this is what I did. I told everybody, I said, wiring this is gonna be a bear, so just hang tight. So I used a microcatheter, and I wired it. Sorry, this should continue to play. Sorry about
So you
that.
you left your guide in the proximal segment, Mark.
What do you mean?
Oh, so you left the JR in the proximal segment.
Mm-hmm.
I would have. I guess I didn't. I thought you would have had to put the guide all the way in to get to the distal.
Yeah, and
Yeah.
Microcatheter to wire.
right.
Yeah, IVUS.
Well, so it is playing a little bit. I don't know if on the right there, you can see. Can you make that right image play, guys, or maybe it'll do it on its own here. Yeah, I think there's not a small neck there, but on the right you'll see that I did wire something, and I injected contrast through the caravel, whatever it is.
Wow.
Is that good? So I thought that looked small to me. That distal right. Yeah. I thought it was a side branch, and so I rewired this. I left that down, picked the microcatheter back up, and then on the left you'll see that I'm taking a wire down. It's through a microcatheter, so this part's easy. And then I put it somewhere else because I thought that was a branch. And then I
That
was
looks like a real vessel.
right.
So what wire did you use?
You know,
Just a regular old
actually a Fielder FC.
builder.
Yeah, just total control, little. And anyway, and I IVUSed. And that allowed me to be very certain about what size I would use. And so some variation on the theme that everybody's talking about, I used a Guidezilla. And I went distal to proximal, figuring that if I could anchor that distal, and I'll just unsheath, I think it was 4 or 5. I think it was 4 viruses.
How did you size it?
Well, so I IVUSed the distal, and I IVUSed the proximal,
Uh-huh.
and there were 5 millimeters.
5 millimeters.
Yep. So I just put these in, and I post-dilled to 5, 5.5, made sure that each of the junctions was well tacked up with each other. And then, here's the final.
Oh my God.
I have to run. I have to go present this in the coronary session. Is that okay? They love shit like this. So, and then we did, this is not super recent. We got a CT. This is just a still frame, but you can see all those devices. And on the right there, you can see that nice circular thing within this now not filling aneurysm. So I think we talked about all the stuff already, but yeah, confirming that distal wire position I think was pretty key. I think otherwise I would have had these small little viruses in there, and I don't think it would have worked. Guide extension unsheathing I thought was a cute idea. And then I'd use a vibe on it. I'd do it again, the large guide. Yeah. Even a big one? 8? Yeah, you might be right, because it'll go through a 7 sheath, correct? Yeah. Right. Okay, so I did it the right way. Good. If I'd do it again, I'd do it the exact same way. Yeah. And the VBX is, I don't know what the, I think the longest VBX, balloon expandable, which will go through a smaller. God, I can't remember the longest one.
Did you get a sense as to where this pseudoaneurysm was originating from? Like, where was the mouth for this?
Yeah, I don't understand it either. Yeah, I don't. I don't know why he had such a mammoth aneurysm. I don't know if it was iatrogenic. He did get a biopsy before. So, because I don't think it was the actual laparoscopic surgery at the time that caused this, obviously. But, yeah, I'm not quite sure of that.
They must have nicked the right coronary artery or something.
Right. And
Somehow.
they created this.
Yeah.
Maybe the biopsy. Yeah.
Wow.
Yeah.
What
Yeah, I don't know. This was a
Yeah.
hernia repair. He had something in his chest. He had a couple chest CTs. He had a biopsy. He definitely had a thoracic procedure years prior.
But they would have had to go through the pericardium to
I know. I think
nick
it's
the right
weird.
coronary artery.
Yeah.
I mean, that's...
And you saw his left, there was nothing wrong with his left coronary. So it wasn't like he had aneurysmal disease or some post. Right.
Mm-hmm.
Be somewhere else.
Yeah.
What's the longest papyrus they make? Because I mean, we have them for emergencies, but I don't know that we have them that long.
I think
5 or so.
How
It's
many?
like
5,
20
I think.
millimeters.
No, they have longer. Papyrus, they have longer than, papyrus,
26.
29.
26?
26 or 29.
Yeah.
Yeah, sorry. I think
Is
it's
that, and that's what you used?
I used a bunch of, we don't
They
have that
foreshorten.
many. Yeah, and they foreshorten.
when especially when you dilate them large.
So
yeah.
I think I used 3 26s and a 19 because I was running out.
We're floating at some point with the papyrus in the center of the aneurysm, and the delivery is still okay.
Yeah, with that, I think that guideliner helped me.
Because that pole could sway one way or the other.
Yeah, I
You're
know.
Trying to deliver the stent.
Yeah.
So that's why Jason's idea of doing proximal to distal is actually a brilliant one, because you don't actually deploy the
Yeah.
distal stent, and then you
Although-
have some struggle because your stent is like a freestanding pole in the aneurysm
Right, I get it, but I always had the guide extender.
across.
Yeah, so the very first one, of course, I didn't,
deployed
but after that, I always had the guide extender in
In
the stent
So
I was about to
deploy the
overlap
stent
with.
and then
Yeah.
followed the
That's a good
guideliner and then
technique.
Yeah.
deployed another stents. Yeah.
Did you have to order those 26s for this case, or you had them all in your cart?
We had a few, I had to make sure they would expand to 5. And I think we ordered a couple, and I used one more than I thought I was going to. So we don't keep that many. We just,
Yeah.
because we're,
Mix 'em.
You still have to fill the form.
I had to fill out the
You still have
form.
to fill the form.
Totally. Actually, I started filling it out beforehand. Or not me, but somebody did.
Yeah, great case, Mark.
Thanks.
Thank you. So our final case of this session is the mother of all structural challenges.
So this is given the last case, our last presentation of CVI. Kostas has actually had this 2 years in a row, haven't you?
Yeah.
Yeah, so he has multiple mothers.
I don't know if Paul's trying to tell me that I'm doing something wrong. But no, thank you again. Hope you'll enjoy it. All our struggle. So 9-year-old female. It's a little bit on the theme of aneurysm. 9-year-old female. She has a history of mechanical bental, 25 millimeter onyx, root replacement 2 years ago with sleeping hypothyroidism. She's a retired nurse, so she's pretty familiar with a lot of the things. And she's getting a routine chest CT just to make sure that everything looks. So give you a little bit of an idea what's happening is that she has a large pseudoaneurysm that's originating what I think is right at the where the anastomose, the RCA button. And her bental is working great. Her onyx is working. That thing is slowly but fastly growing right next to RCA. And it was not there a year ago for prior CT. So pretty new. So one of our surgeons gave us a call and he's like, "You guys do something with it?" What would
Great
you guys
setup.
do?
It's kind of like summing up like all the cases we've seen today. Like we're gonna have to now we have a menu of all the things we can do, and we just have to order the right sequence, you know. But I think you can do it. But it's gonna be a little bit of Mark. It's gonna be a little bit of Kashish and a little bit of Harsh, you know.
So first of all, would anyone send her back for surgery? 69 years ago was her surgery. She's pretty healthy overall, but she had a pretty traumatic surgery.
I mean, I think if the previous surgery was traumatic and you really don't want to go back, I think it's safe to try these. So I think it's safe, and if it doesn't work, then you could have surgery.
I think even if the patient is a surgical candidate, if you can do something percutaneous without major risk, I think it's worth a try for the patient, right?
Yeah, and with these pseudoaneurysms too, you know, sometimes you don't close them completely, and you see some contrast patency on follow-up CT, but it can be that way for years and forever, and you just follow them. I mean, they can have this very slow kind of permeation through the whatever occluder, and the vascular surgeons, they usually say, yeah, as long as it's not getting bigger, we keep an eye on it. So even if you don't get an absolutely perfect result, it may be fine for the patient.
Well, that's how we thought. So we should definitely go. I did a root angiogram. You can actually, based on the position, you could say something failed, but I couldn't. Origin, but knowing it was right close to the RCA, I kind of positioned, it's a JR guide, I kind of positioned it right next to the RCA and just dropped into it, so I knew I'm inside there. And you can see the contrast picture nicely filling, and you can see the RCA, pretty healthy vessel. Second thing is, I've done a few of them, and I always was trying to get an understanding of how do things really work, why is it happening, and how close are they truly to the RCA. So this time I tried to Abbas it. I was like, let me see. So I have one wire inside the pseudoaneurysm, one wire into the RCA. I do a Abbas. I only have a still frame because it doesn't really add a lot of things. So you can see my wire, like my second wire is up there at 11 o'clock, and it didn't really add anything to my understanding. I knew it was close to the ostium with the RCA, which I knew from the CT, but it doesn't really change anything on my management. So it didn't really answer to why it happens. So I do them under GAT. Main reason being is I don't know how they're going to behave. So I like having as much stability. I wasn't really counting that TE was going to be able to image it for me, but they did manage to find it. And you can see it's like a nice circular area there. It's beautiful imaging as always. So I can clearly see where it's originating from. I don't know if it changes anyone's strategy seeing it there, but we did try to measure it. I think it was about 7 to 8 millimeters. So when you see, excellent, perfect. Sorry for that. So if you see right here where this little like circle is, that's where your pseudoaneurysm is. It's like you can see it up there. It's nicely positioned. So that area right there is where your true like that's the mouth of your pseudoaneurysm right here. So it comes right next to it, and I think you can see it on CT was actually the best imaging to see where it's originating.
Double barrel.
So it's right here. So that's your ostium of the right, and that is your pseudoaneurysm. So you see here, that's your right with the yellow arrow, so that's the ostium with the RCA. And I think where they put that suture to, for the bental, for the right bental, I think one of those sutures might have like leaked and it starts forming the pseudoaneurysm right next to it.
So Kostas, the interpretation here is that the ostium of the pseudoaneurysm and the right coronary are shared. Is that fair?
Yeah, fair.
And there's
at this point it's shared.
Yeah, there's really not a separate pseudoaneurysm ostium. There's
No, exactly.
So technically, one has to preserve the right coronary artery and the pseudoaneurysm while closing pseudoaneurysm, because you're not going to be able to, whatever you put across this PSA is going to straddle the native right coronary artery.
Well, I agree. But
Okay. Okay.
we'll see.
All right.
Yeah, no, I'll show you. So,
Right.
very nice. So yeah, we say it on T. It doesn't really change our management. If you don't find on T, it doesn't really guide the procedure. It's
Okay,
like-
so we got to talk about this. So what's the strategy here? So, Kashish, Ricciardi, I mean, because you got the
Think
right
plug
coronary
and
artery
stent.
and the pseudoaneurysm both sharing the origin. So
I mean,
how are you
he's
going to
already
manage?
done.
How are you going to close one and keep the other?
Well, he has done already 2 guides, so I think plug with one and stent with one. Be ready with both.
So you used DK stent
Kind
plug.
of without the kissing, but yes. But I would put the guide liner across that RCA, so you plug it and have the guide liner so that you don't struggle with
protect the right
advancing this.
coronary?
Yeah. So wire the coronary guide liner, have the stent ready in the coronary, plug it with the other guide, and then on the way back just stent the.
Yeah.
Yeah, I would
Well-
do the same. I would have a stent ready in the RCA, and then I would do an AVP, just have the disc of the AVP out, and then basically just jam it into it with the stent hanging out a little bit.
Yes.
Overinflate the stent and crush the AVP?
No, like not crush. Like basically it has to cover the part of the disc, so it doesn't like pop out later or move or come back into the coronary, because we don't want a coronary infarct later on as well.
Yeah.
And I'm just thinking about this for a total of 20 seconds, so it's probably all wrong, but I would worry a little bit that unless you perfectly cover the entry into the pseudo, that you would leak through the right. So I would do what these guys said, but I'd do it with a covered stent.
Very good.
So
Which one would you?
cover stent in the right?
I'm just in that mood right now. Yeah.
Well, you used up all the covered stents in your last case, so I don't know.
But you know what I mean? I think that unless you perfectly sealed that entry of the pseudo, you may still, the right coronary perfusion may still.
It's a great thought because they share ostia,
Yeah.
and we don't want flow through a stent into that PSA. So
Which one would you do first? Would you put your plug in first and then stent? Would you put your stent in first and then plug?
Stent.
So stent, cover stented,
and then,
put your plug.
pull the plug against it.
Yeah, but I would keep everything in the right, but with the stent in place, and then play around with the pseudo, and then at the end, probably.
Sounds like Kashish should do the other way, huh? Plug and then.
Put a plug in first, because otherwise I'll have to go through the stent struts, and I'll have to leave one of the discs into the coronary artery to prevent having issues. But people have, if it was a small pseudo, then people have done it, put a stent in, and then just coil through it. Then it's fine. But this is not coilable.
And the stent
Yeah.
would need to be out in the aorta a little bit for sure.
I like Kashish's idea of doing the AVP 2 first and then have the stent there in place. The one thing is that the AVP2 has a hub, right? There's this little thing sticking out, and that's right where you're going to put the stent. So you have this little metal projection, so maybe that interferes with the stent. But I'd probably just use a regular DES. I don't like putting covered stents in native coronaries if you don't have to.
Those AVP2s, they're designed to clot. So anything hanging in that area, it just creates a little bit of unknown risk.
Well, I don't know if anyone has any other questions, any thoughts, but. So very similar to what you guys said. So we wired both guide extension in. I picked a covered stent. And I picked a covered stent because I'm always worried that if you don't get a perfect deployment, as you said,
Attaboy.
it's going to leak around it.
You work for Papyrus?
You got one from Chicago.
To declare that.
They are our gold sponsors for this session.
It's wire in, guide extension in. You have your coronary stent ready in place. The only thing actually the Abbas helped me realize is where is the true ostium. So I knew where the ostium of the right is. So I knew how much I have to get outside and how much room I had to deploy the stent. So Pretty much, we put a we put a 6 French JR4 inside the pseudoaneurysm. We bring an AVP tube, 10 millimeters. Was always told to put like that through a 6 French guide. You can definitely put a 12 millimeter AVP tube. What I learned that day is that doesn't go through every guide. So I don't know why. I know that if you look on the no, it actually was in the middle of the body. It was getting stuck.
You had a wire also in the guide or no?
No.
Oh.
So Cordis was actually the one that was only able to put the device through, and I don't know why. If you look at the diameters, they say that they're all equivalent, but
Yeah, they don't match up.
No,
yeah,
for sure not.
So, but the cord is 6.
yeah.
We'll
So
hold it
Cordis
12.
6 will go.
Yeah.
So
It's interesting for LVAD exclusion. I put an 8 French, I put a 16 or a 14 through it for LVAD graft, and then that's where the cordis actually has a smaller lumen diameter. It's
yeah,
opposite.
and that's what I'm saying. Like if you look at the paper, if you look actually in the box, like the Cordis theoretically doesn't have the biggest lumen, but I learned it the hard way that day. Like I spent literally 30 minutes trying to push my device, and it would just not come through. And it got to a point where it was like, just find me a Cordis, and it literally just pushed through the device very easily. So, yes.
Is kind of back in the aorta, right? I mean, it's not really sitting in the ostium, right? For the AVP, the proximal disc.
Yeah, so my plan of deployment was actually the middle disc, squeeze it at the ostium of the pseudoaneurysm. Let my proximal disc overhang in the aorta, so that way I don't create like a closure in the RCA with that disc, and then my distal disc will be inside the pseudoaneurysm.
So you're keeping the distal disc away from the ostium in the right corner.
Exactly.
Yeah. Because
So
of the risk of thrombus.
I'm trying not to like create, like I knew it was going to overhang. My plan is not to let that device.
So why not put the 2 lobes into the aneurysm and 1 lobe outside?
'Cause
That's what
did-
I would have done. Like put the 2 lobes into the aneurysm and just have 1 lobe back it up. at
Because
the ostium.
ideally, I would like to get the max compression of that pseudoaneurysm with the body of the AVP2. So instead of just having the little spacer like covering the pseudoaneurysm,
He's worried about the disc being too close to the right coronary.
Yeah.
Yeah.
There may
This
not
is a
be
way of
enough
keeping it
room
far away.
for the proximal disc to fully expand also,
Yeah.
because it's in that
Yeah.
little. Right.
But
so-
it's hanging out further than it would
Yeah.
be if it's
Exactly.
pulled in.
And you can see actually the guide is still engaged into the right. So I know that the proximal disc is actually sitting in the aorta. So it's not touching my ostium there. I know I'm covering the ostium of the pseudoaneurysm because I have a really nice compression. You see that middle disc, the device has elongated, it's compressed. So I know I'm closing that ostium of the pseudoaneurysm.
Yeah, and I don't think I would have done TE here, but I think that's good that you did because you could take a look at this stuff
Exactly.
very quickly.
Yeah.
How big was the waist on the CT of the pseudoaneurysm?
They couldn't measure. So you saw the picture. They're like, because they can't take a full circular, they never.
What I'm just thinking is, did you really need a 10? Because, maybe a 6 would have been enough for compression because it looked very small.
So
at
I
the
did
waist.
actually try a 6 at that point of desperation when my guide was not working and it just popped out completely. So I did. So 10, I felt like it was really nice compressed. TE was getting me 7 to 8 millimeters, so 10 also makes sense. Like, so it needs to be a little bit bigger. So right now I'm in a position where I'm still holding the plug. It's in place. I've tugged it. I'm pretty confident it's leading well. Doesn't interfere with my mechanical valve, which is great. And I'm still filling the coronary pretty well. You deploy it?
Deploy what?
The stent. The RCL RCA stent.
Right.
Yeah.
Okay.
100%.
Very nice. So what if you you pull back your guide and you just have your guide extension in and you're still filling?
False sense of security for me.
Thoughts? Yes. Yes. I didn't
That's
know.
what Kashish
Yeah.
you had asked. Yeah.
Yeah. So the reason I did not want to release it completely is because I didn't know if I were to deploy the stent, how it would going to interact with the device. So I wanted to have a, yeah. So you would all deploy the stent.
Yes.
I think that's the,
I would actually release the tension on the cable and try to get a sense as to where the plug is going to be, then deploy the stent, but still leave the cable attached in case I didn't like it.
That would be your last move.
My
Your last move would be
yes.
the plug.
Yes.
Yeah.
See,
So-
right now you're pulling on the plug, but I would give that tension back.
yeah. So which is exactly what I did. So I pushed in, we did not save, unfortunately, all those are moved. So I pushed in the wire a lot because I knew I was still attached to it. So I pushed it in, I let it see how it's gonna function on its own, like without like me pulling on the device and see how much it's gonna interact or not. I felt that it was safe to deploy the stent because I really did not know in a few months how things were gonna behave. So I wanted to like maintain everything we've achieved, and going back through the device, it's gonna be really hard to stent it. So since we were there, you can see like I left the device in neutral position. We deployed the stent. And that's what we got on TE. So perfect seal, coronary's patent, and it's kind of an added bonus having the TE there, knowing that you can nicely see that it's perfect seal. It makes actually things look better. So this is just our final picture, making sure that everything is looking good. I did not repeat the aortogram, main reason being like I couldn't see the pseudoaneurysm on my initial one. I'm not going to see it now. So
The disc is very close to the ostium, right? The hanging
is.
out disc.
So that's why you get a CT at 30 days. And well, I always joke that CT won't lie, so we'll show you what you did. So it's very close. It doesn't close it off. So you can see the papyrus stent expanding a little bit into the aorta. The plug is right behind it. I put it in the middle, actually. You can see that little like C shape that's like you saw on fluoro. It's actually how it closed off in the CT. And I think that little like upward facing is what helped us like keep the RCA free. And also it helps you maintain, making sure that like you're nicely compressed and like it's a nice closure there. And you can see the RCA is filling pretty nicely. So she's doing well, chest pain free, no issues, normal EF, patent stents, and all I have. So.
I would keep this patient on anticoagulation, though. It's so.
I mean,
as
she
Paul
has a
said, these-
mechanical valve,
Oh,
so
has,
she's
yeah,
going to be
forgot.
on warfarin. So that's the easy part there. I was going to keep her on Plavix warfarin for some time. She's young, so I don't know how. The good thing is that papyrus is 4.0. It's not like a small papyrus, so hopefully with like the anticoagulation, things are going to be easier. The one thing, and I mean, I'll open up as a question to everyone, is like, how much do you think the warfarin will affect clotting of the device? And that's always been like our problem. Like, do you think it will affect, like, it will decrease the chance of the device clotting off? And
I think these will endothelialize within a few months, and they will clot off. Yeah.
nothing else. No, it's more a curiosity. Like it always comes. Yeah, it always comes up as a question too. Yeah. Thank you.
Great case, thank you.
Fantastic. Well, that's a wrap for our main sessions in CVI. It's been a wonderful conference. I want to thank you all for being here. We continue to grow, and I hope to see you back next year in Denver. For those of you who are interested, we do have our challenging case finals next door, and there's a lunch there if you like. Come watch. But otherwise, safe travels, and really appreciate you all being here and helping us make this a success. So thank you all.
Quick applause for Paul Sorajja.
No.